We're thrilled to have him here, so everybody please welcome Dr. Jhawar.
Hello, everyone. Thanks for asking me to come over here. And as a part of my introduction, I will tell you how I introduce myself to the class of residents and fellows. I would say to them, chronic cough, shortness of breath, wheeze or sneeze. Call me, please. And if poor sleep, tired during the day, don't worry, I'm on my way. So that's what the spectrum of things which I do related to pulmonary medicine and sleep is. And I promise you that my talk is really simple and not too much of data-driven, but has tons of tips for the practical management of respiratory issues in neuromuscular disease patients. My original or the primary area of work is cystic fibrosis and pulmonary diseases, and I see a similar model which Cystic Fibrosis Foundation of North America exercises, in which we take care of the patients as a team, including all other subspecialties involved. And the newest dimension, while newer medications such as modifiers are coming in, is to make sure that as these folks survive longer, their day-to-day respiratory quality of life is better taken care of. And as they continue to live longer, healthier, some of those issues become very prominent on a day-to-day basis. How do I move this? Oh, this one, here, okay.
I didn't break it, I swear.
So this first slide is the simplest presentation of the 4 important components for effective breathing. You need a command from the centers in the brain, most commonly originating in the lower or the middle part of the brain, and that transmitted through the neuromuscular route. So that is the first component. Second component is this command coming from the top is for the muscles to act to lift the chest, expand the chest, and push the diaphragm down. And these 3 things are going to generate that negative pressure which is required for sucking the breath in. The third component is that while this negative pressure is being generated, the airway is dilated and open because it requires tongue to be out and then the pharyngeal dilator muscles to keep the airway patent and open. And this is also, again, a neuromuscular phenomenon. The next component is, while this is happening, there should be least of the obstruction in the airway. Any kind of enlarged tonsils, adenoids, soft tissues, big tongue, those are the common obstructions, so those obstructions should be out of way. And then comes the next component, which is you have to have a healthy lung, and a healthy lung is defined by its property of compliance, that is the ability to open with the least amount of pressure and elastic recoil, throwing it back to the normal lowest volume so that they are ready for the next breath. So those 4 components are very important, and I will tell you that the compromise which you get with the neuromuscular disease is, number 1, it is secondary. But the most important part is that it happens more at the times when you are in most need. While awake, you may be all right, but while you are sleeping, that becomes a problem. Or when you are trying to recover from a respiratory infection, that becomes a problem. Or when you are trying to do some activities or exercise, that becomes a problem. Or when you are trying to complex the tasks such as eating and breathing and talking, and if the coordination is not good, then that becomes a problem. So what the neuromuscular disease mainly does is it reduces the ability to get the breath in and out. The technical word is hypoventilation. And as the ventilation gets compromised, the delivery of oxygen and elimination of carbon dioxide gets compromised. The second component is that each breath, as it moves in and out, particularly as it moves out, is a mechanism to keep the airway clean. And imagine if mucus is not cleared in time, or all the particles and the viruses and the bacteria and the aspirated material, if we cannot clear it in time, we are asking for additional problems related to problems such as asthma, problems such as recurrent pneumonias. As I said, that the coordination required between swallowing and breathing, particularly at the younger ages, can be problematic, and it may end up in aspiration, and that kind of sets another set of problems from the respiratory aspect. While this is going on and the growth is coming in, and remember, one part which I always like to talk about growth is that growth does not come all of a sudden, all of it at a time in all organ systems and all tissues. There's different timing. In a growing child, at the time of rapid growth, if the neuromuscular balance on the two sides of his spine is not correct, the likelihood of developing scoliosis is higher, and that reduces the mechanical efficiency of the chest. How? A normal chest with a straight spine and ribs coming out at an angle, with each inspiration you do this bucket handle movement, and that bucket handle movement is responsible for expanding the chest and helping you to take breath in. With the spinal curvatures, that movement gets compromised. So your ability or your burden to take an effective, complete breath also gets compromised. Now, I know I was talking to Dr. Diane, my colleague in cardiology, and was telling that, hey, remember, we are neighbors in the chest. And you're going to talk something about me, and I will say something about you. As the cardiac function starts getting compromised and weaker, a difficult breath can only add to the burden. Because remember that an efficient respiratory system relies between the matching of the ventilation to the perfusion. So that can become another additional limiting factor. So what do we do in our neuromuscular clinic to evaluate these patients? We try to get as best history as we can and focusing on different aspects, because respiratory aspect is very dynamic. It is not same all the time. So you have to ask that whether the symptoms, and the symptoms can come from airway, such as cough, wheezing, tightness in breath, or they can come, or they may be related to lung parenchyma, such as shortness of breath and low oxygen. But you need to ask during awake, during asleep, with activity, and with sickness. that will give you the most comprehensive description of the respiratory symptoms and also what provocates those respiratory symptoms. We specifically asked for sleep-related symptoms and any disruption in the sleep, frequent movement, daytime tiredness, daytime sleepiness are the highlighters. Now remember, in a slowly progressive condition, folks get so used to seeing it, experiencing it, and tolerating it that they will not come out to tell you the symptoms right away. And that's why you have to ask it again and again and from different perspectives and figure out if everything is really normal or it needs your attention. So as I mentioned, the clinical presentation can be shortness of breath, orthopnea while supine. Now, in neuromuscular patients, I always pay extra attention to the posture part and its effect on breathing. The normal physiologic parameters of supine versus sitting, okay? Your vital capacity goes down by about 10% when you are supine. So your breathing is less stressful when you are sitting straight or when you are standing, but as you lay down supine, that gets compromised, and it can become an additional factor. Now, we are going to talk about all the additional factors which can come in neuromuscular patients as far as increasing their respiratory burden. So asking that how do you feel when you are laying down or when you are sleeping as far breathing is an important part. Then, as I mentioned before, poor, fragmented, non-restorative, and non-refreshing sleep, daytime fatigue, tiredness, shallow, fast, noisy breathing, because neuromuscular disease brings you an extra element of restriction to the pulmonary function. And the way you deal with restrictive problems, respiratory-wise, is there are two ways of dealing with it. Either you try to generate increased tidal volumes, open up and take a big breath, but that requires lots of muscle. Or you can go up on the rate. So frequently you will find the rate of breathing is higher and breathing is shallower. Now, there is one additional thing which I say in context of increased rate of breathing, particularly at the younger ages and the growing years, is each breath costs. It takes calories. Your higher breathing rate is higher caloric expense. So it can put you at a point where you need extra calories. So it is not uncommon to see respiratory patients with active problems not thriving well, okay? Of course, if there are airway-related issues, then there is going to be coughing and wheezing, poor cough, poor swallowing. Now, in clinic sessions, when I talk to patients and families, I ask this from different perspective because I think breathing out can be assessed in many ways. Are you able to talk? Are you able to giggle, yell, sing? If my patient is crying, then I know that there is good respiratory effort going into it. So any compromise in the breathing, because when the breathing gets in trouble, most of the time they like to sit in a corner, not talking to anyone, not interested in eating, just basically leave me alone, I'm dealing with my own problems, okay? Then how do they do when they are eating? And particularly when it comes to eating and swallowing, you have to ask about thin liquids, juices, water, because those are the difficult things to push down, okay? And those are the times when they are more likely to get aspiration and the problems related to that. In clinical exam, I pay attention to, this is the basic scheme for any medical doctor: inspection, palpation, percussion, and auscultation. Inspection-wise, I pay attention to how symmetric their chest is growing. How's the spine? How are the ribs? Sometimes when the chest expansion is not adequate and the lungs are not opening up because of some reason, you will see very obvious retractions. You may see either bulging or sucking of the sternum, pectus deformities. So giving a nice, careful look to the chest in context of symmetry and in context of effort for breathing and in context for rate for breathing is important. And of course, you would like to confirm some of these findings by palpation. And I use percussion, and I am a big proponent of doing percussion in pediatrics particularly, because the chest walls are thin, and what you have to do is you just basically percuss to estimate whether there is adequate and appropriate air in the lung. Okay, a lung which is not inflating adequately probably will be a little bit dull to the percussion compared to somebody, for example, who has asthma and their lungs are full of air, and then they will sound like drum when you percuss. So it may not be as great of an art in adults and older folks because of the distance from your fingers to the lung with the muscle and fat involved in between. And then, of course, auscultation is important, and I look for the symmetry of breaths on both sides. I use my old-time dual-head pulmonary stethoscope where I can listen to both lungs at the same time in my pulmonary clinic, but most of the time when I'm in the neuromuscular clinic, I try to grab one of the freely available stethoscopes from the clinic to listen to. But what I'm paying attention to, that breath is entering on both sides, and I pay attention to the timing for breathing in and timing of breathing out. Normally, breathing in time is shorter than breathing out time, but if the breathing in time becomes prolonged or breathing out time becomes prolonged or they become disproportionate, it tells me that there is some issue going on. Either it is related to muscle weakness, or it is related to airway problem, or maybe it is related to lung tissue. The next thing which I do is pay attention to what the stethoscope are really meant for, and if I hear any kind of adventitious sounds, any crackles, any wheezes, then I need to make sure that they are falling in the line of rest of the clinical exam. I do it in 3 steps. I will listen to the chest without giving any command, or then I will ask them to take a bigger breath and then listen, and then I will ask them to cough and then listen. And what that does is that basically takes away those secretions out of picture which can be causing like crackly sounds and what I call sometimes coffee percolated type of sounds because the secretions keep on rocking. But that clears or gets modified. If it doesn't get modified, then those are kind of true crackles, and those might be related to lung disease. Investigation-wise, I'm a very big proponent of spirometries in clinic, and these are simple, easy procedures, not too much of cumbersome equipment. And what they are asked to do is 2-step, blast, and continue to blow, 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 blow as far as you can. And now with these 2 maneuvers, I assessed 2 very important things. The force of the blast which is coming out is telling me how strong the muscles are. And the complete emptying, what we call force vital capacity, is telling me that till the end they are able to squeeze all the air out. Okay? Now, the suggested parameters to say that your respiratory or ventilatory function is compromised is when the forced vital capacity becomes less than 50%. Okay, and I will tell you that this again falls in two different categories of symptomatic versus asymptomatic patients, and also the pulmonary comorbidities, because you might get alarmed even with a higher number. But 50% is an absolute concerning number. Then we also do the maximum inspiratory pressure and maximum expiratory pressure, okay? Because taking a breath in is a very active neuromuscular process, 100%. It also depends on the compliance of the lung also, but breathing out is quite a bit of passive recoil of the lung tissue. So it is the start of breathing out and the terminal portion of emptying the lung where neuromuscular part is most obvious. Middle part is basically reflecting the state of lung. So cough velocity, maximum inspiratory pressure, maximum expiratory pressure, and then the forced vital capacity. We also have equipment for measuring end-tidal carbon dioxide, because if the breathing is compromised, then the end-tidal carbon dioxide is going to be higher. It is very breath-to-breath dependent. But if you see a value more than 45, that is quite concerning. A pulse oximetry of less than 91% on room air while awake or 88% while you're sleeping is concerning. There's about 5 to 10 point difference between the awake CO2 and sleep time CO2, and there's about 3% difference between the oxygen saturation while you are awake and while you're asleep. And if it starts touching about 5%, more than 5%, then you get concerned that probably the low oxygen or higher carbon dioxide is because of poor ventilation. If I have an availability of chest X-ray, that comes pretty handy in estimating the lung volumes and also looking at the spine and cage, but most of the time it is not there. If it was done for a different reason to evaluate scoliosis or other problem, then that gives me some information about how much lung volumes are being generated and how does the chest cage really look like. This next item is what I call poor man's sleep study, which is just doing basic electrolytes. If you do basic electrolytes and if you see higher bicarbonate levels and lower chloride values, then you know that kidneys are trying to compensate for retained carbon dioxide. Okay? So higher bicarbonate levels, let's say more than 27, are concerning about the nighttime ventilatory problem. Complete blood counts, hematocrit, and hemoglobin. If you're hypoxic, chronically hypoxic because of ventilatory compromise, then your hemoglobin and hematocrit is a little bit on the higher side. What I really mean to say is that some of the basic routine regular values of these labs, which were done on most of the patients by one of the providers, can be really helpful for you to make an estimate about the respiratory status. Now, ever since I joined maybe 3-4 years ago, the neuromuscular disease group, I am aiming towards almost 85-90% sleep studies on these patients. Why? Because they are not telling me the symptoms, and by that, if I wait for the problems to show up, it might be a little late. Okay? So doing a sleep study on these patients is very helpful in giving you some baseline data, which you can compare later on, or a data which will make it obvious that there is a problem going on and an intervention is needed. And Respiratory exercise testing, and I think Dr. McDonald was showing you even simple things such as walking test and how you tolerate that exercise and what happens to your heart rate and oxygen saturation and breathing rate. Those are also important parameters for respiratory assessment. Sleep studies, as they are also called as polysomnographies, because there are multiple data items which are collected out of those. But for the sake of simplicity, the 4 components of sleep studies are very important. One is identifying sleep and defining sleep architecture based on physiologic parameters, not just the behavioral parameters that I'm sleeping, my eyes are closed, and I'm not moving, but depending on your EEG, EOG, and EMG, what kind of stages, what kind of periods, and what kind of cycles of sleep I'm going through, and if the architectural pattern of that sleep period looks normal. So identifying the sleep characteristics. And then looking at the respiratory parameters, how chest is moving, abdomen is moving, nasal oral airflow is coming out, what's happening to oxygen saturation, and what is happening to carbon dioxide. Those multiple parameters are very helpful. And when you plot them side on the same sheet, you can say that at this particular point, this is what was happening with the sleep, and this is what was happening with the respiration. And of course, we have EKG and a video recording of movements. So if the sleep waves are saying there's a problem, and respiratory pattern is saying it's a problem, and the heart rate is going up and down, that's a problem, and then there's a lot of movement happening, now I can say solidly that this is not a restful sleep, okay? And I can identify whether the problem originated through the respiration or through the brain waves or through the cardiac parameters. Okay, so I think the sleep studies are very, very valuable, and they should be done as early on as possible. Poor sleep in neuromuscular disease patients. What is the usual pattern? Sleep fragmentation is very common. Now, let me spend a teeny bit of time in explaining the sleep architecture. A normal sleep architecture consists of 2 different stages of sleep: rapid eye movement sleep and non-rapid eye movement sleep. Non-rapid eye movement sleep, as I say in simple words, is brain sleeping, body sleeping. Okay? And if your brain is sleeping, if your body is sleeping, who is watching the respiration? So it's the chemistry, the carbon dioxide, the oxygen, the pH, they determine how you are breathing, and that pattern is pretty regular, and because it's going through the levels. So I think the non-rapid eye movement sleep, and then the rapid eye movement sleep is when brain is awake and body is sleeping, and that's the time when dreaming comes in. That's the time when the muscles get relaxed, and that's the most problematic time, particularly with the neuromuscular problems, because you do not have that much of tone to generate adequate, efficient respiration. Fatigue, tiredness, sleepiness, poor mood, cognition, memory, emotion, they are all described with the poor sleep. There are lots of metabolic components in glucose regulation, weight regulation, which are involved with the poor sleep. So what do I suggest these folks? I do suggest these folks that they get the airway evaluation done, and if there is anything obstructive that needs to be taken care of, and in clinic, we usually, depending on the situation, we ask for airway clearance support equipment and nighttime ventilatory support equipment if it is needed for them, and troubleshooting those issues. One of the things which comes quite often is some of the medications which are used for muscular dystrophy patients, such as corticosteroids, and they have a potential for weight gain, so that gets disproportionate, and then the breathing burden actually goes higher. The other issues which I see is with the corticosteroids, such as prednisolone, which crosses blood-brain barrier, there can be problems with the sleep architecture and disturbances. So I think somebody raised the right question that, when we use all these medications, what are the kind of side effects which can be problematic? But most commonly, making sure that their ventilation is good at night when they are sleeping, making sure their airway clearance capacity, abilities are good, and they are getting the proper equipment support. And of course, these are the goals and objectives. But here's the last thing which I want to say, that my presence in neuromuscular disease clinic is based on a simple concept of preventive, promotive, protective respiratory care, because adding extra problems to already existing problem is not worthwhile. It can be some asthma, it can be some pneumonia, it can be sleep-related problem, it can be overweight-related problem, and any of the additional burden which is coming on respiration, on the weakening muscles, is not worthwhile. With that, I will end this. Any questions for me?
No? Yes.
I apologize, I came in late. Did you discuss cough assist at all, and when you introduced that?
Yeah, cough assist should be used starting early on. And even for a year-old, you can give cough assist. The important things which you need to keep in mind is cough assist is a machine which gives you a bigger than tidal breath and then creates a negative pressure like a vacuum cleaner, okay? So if it is done on a full stomach, these folks are going to end up puking, okay? So the timing of use of cough assist is very important. It should never be done on a full stomach. But cough assist, symptoms or no symptoms, started early on because there is always a learning curve, and how often should they use. I think it should become a regular practice for them as toothbrushing is for someone. And over a period of time, they learn how to use it. And of course, you see its utility most clearly when they are going through a respiratory infection and finding it difficult to clear the secretions. But not being able to clear secretions does not mean that they did not rock any mucus in the airway with the cough assist. You are going to ask.
So you were mentioning that a lot of the times patients won't tell you the symptoms because they get used to it, and we are missing those patients in terms of caring for respiratory treatment. So what would you recommend for other physicians who are seeing these patients in order to basically have them, tell what the symptoms are so that they can be referred to the right people?
Yeah, that's a very good question, and that actually touches right to my philosophy of taking care of these patients. Highest index of suspicion, broadest spectrum of your questionnaires, trying to get the answer which you are trying to look for from different perspectives is one subjective way of getting this teased out. And then you have these physiological studies which tell you if the problem did not become as obvious during your subjective component. So ordering sleep studies for these folks is a great way to explore multiple items. And as I said, that cardiac, pulmonary, sleep, and if there is anything else going on. Because if your health is good, then nothing should be bothering the normal physiologic pattern of sleep. Okay? Sometimes there are limitations in terms of doing the breathing tests because the cooperation and understanding, so that part gets a little bit compromised. But evaluating these parameters during sleep is pretty passive way. So you can still get better information from there. So asking for doing sleep studies, doing spirometries, checking their CO2 values is actually very important in clinic, because that can be the earliest good big indicator that there's some kind of ventilatory compromise going on.
Great. Thank you very much, Dr. Jhawar.
Okay.